Good day, this is Dr. Amr Ratib, consultant of dermatology in Egypt. I'm speaking to you from Cairo. I hope next year we'll meet in person, physically in Canada, inshallah. Today, I'm going to present the topic of acne scars, pathogenesis, prevention, prophylaxis, and treatment management when they happen. Acne vulgaris is a very old, annoying problem to human beings. The first reports date back to the 6th century. Acne affects up to 85% of people between the ages of 12 and 24. Acne can continue to the age of 45 years in 12% of women and 3% of women. It's one of the 10 most common diseases worldwide. It is one of the first 2 reasons for dermatologist visits worldwide. It affects the quality of life negatively, and the effect is comparable to that of psoriasis, almost as equal as what psoriasis does to people. On the other hand, it's worse than what diabetes and coronary heart disease does. Acne pathogenesis is multifactorial. Acne does not follow the same pattern in all the individuals affected. Many factors are working, and it is not fully understood until now. Anyhow, we are going to concentrate in this talk about the genetic factor, ethnicity, the lifestyle, the inflammation, the neurophysiology, and the microbial factors, because these factors are related to the scarring in acne. First, inflammation. This is the most crucial factor in induction of scarring in acne. Even the very first non-inflammatory lesions of acne, the closed comedones, lymphocytes are colonizing there. There is inflammation deep inside. It's subclinical, but it is there. Polymorph nuclear leukocytes are present in all the evident inflammatory lesions, papules, pustules, and nodules. The arachidonic acid cascade products, whether the cyclooxygenase pathway, the prostaglandins, or the lipoxygenase pathway, the leukotrienes, are present in abundance in the lesions. Interleukins 6, 8, 17 produced by T helper 17, leukotriene A4 are all present there. The effect of the lipoxygenase pathway is so important that there are trials now to introduce a treatment to stop the lipoxygenase pathway. Maybe it will help the inflammatory acne and it will prevent scarring. The production of sebum by the sebaceous glands, the activity of the sebocyte, the maturation, differentiation, proliferation, lipogenesis are all under control of many neuropeptide and neuropeptide hormones, like the corticotropin releasing hormone, the melanocortins, the beta endorphins, vasoactive intestinal polypeptide, neuropeptide Y, calcitonin G related peptide. They all modulate the function of the sebocyte. In inflammatory acne, substance P appears to be the most potent effector neuromodulator in inflammatory acne. It's very potent induction of inflammation, and it is affected directly by psychological stress and emotional stress. One of the most important factors in induction of inflammation in the pathogenesis of acne and even in precipitation of scarring in the lesions is the activity of the Cutibacterium acnes, or what was previously called the Propionibacterium acnes, and its lipopolysaccharides. It upregulates the inflammatory mediator release, interleukin 1, alpha interleukin 1, beta tumor necrosis factor, alpha interleukin 8, granulocyte, monocyte, colon stimulating factor, interleukin 17, again by sebocytes and keratinocytes. Cutibacterium acne stimulates the release of antimicrobial peptides. Therefore, the Cutibacterium acne in itself carries its control mechanism. It stimulates the skin, whether the keratinocytes or sebocytes, to produce antimicrobial peptides to stop the activity. This explains why many cases of acne, actually, if left alone, will go finally to self-control. They do not need us. And Cutibacterium acne stimulates the formation of free fatty acids. These free fatty acids are bactericidal against the Cutibacterium acne. Again, this is a self-controlled mechanism again, and the free fatty acids may by themselves induce the inflammation. So you see here that the situation is very complicated between provocative and controlling mechanism just by one factor, which is the Cutibacterium acnes. Ultimately, we see whether closed comedons, the white heads you see in the photo, or the black heads open comedons, or the different types of inflammatory acne, or the end stage, which is scarring, whether depressed or hypertrophic or keloidal scars. Scarring generally is worse in contaminated and complicated wounds, and if we put this to acne, yes, it's in a way contaminated by microbes. Scarring happens when the damage affects the reticular dermis, the hair follicle, the area of the bulge where the stem cells are there. This is the area of the inflammation in acne. Key factors in scarring is inflammation, and there is a genetic factor that pushes the scar to be hypertrophic or keloidal. This is scarring in general. In acne, we can predict that the acne is going to be difficult to treat and may leave scar when the acne starts pre-pubertal, when the acne persists after the age of 30 years, when the acne is severe and is associated with psychological morbidity. Here, the style of life, the psychological morbidity, the stress may provoke the scarring by pushing the patient to pick up or play with the lesions, or vigorously clean the face, trying to get rid of the affected inflamed lesions. Moderate acne may produce scars in 30% of patients. Even moderate acne can produce. So again, we can predict scarring in acne when it is pre-pubertal, when it stays to later in life, when the patient is psychologically depressed, when it is severe, and in 30% of moderate cases of acne. Again, pathogenesis of scarring in acne is the same as the scar everywhere: the inflammation, the granulation tissue, the wound contracture, and the tissue remodeling. Now, these are the types of scars we see in acne: ice pick, box scar, rolling hill, puckered, atrophic, hypertrophic, and keloidal. Different types and very interesting names. What is ice pick, box scar, rolling hill? Where did they get these names? Here, how they got these names. This is the ice pick, and this is the box scar, and this is the rolling hill, and they artistically describe the shape of the scar in the face. So prophylaxis, avoiding the scar, avoid all sorts of trauma, and here I stress upon friction. This is the commonest problem I face in my practice. There are many special soaps or washing material or scrubs that are formulated to treat the acne, and the media stress upon their value. These lotions or creams or soaps may be good in their composition, but the patient tends to rub the face vigorously, feeling that they are being very honest in treating their skin. And this is how to get rid of the acne. This friction will stimulate acne to be more and more inflammatory, and even superficial type of acne may go into deeper one by repeated pressure, by friction. Nevertheless, not to mention picking and squeezing, trying to clear the lesions to the extent of the excoriated acne. So to avoid scarring, we have to stress on the patients: please do not touch your face unless you are putting the medication you are prescribing. Do not go into vigorous washing. Early intervention with early treatment, of course, will stop the inflammation and will improve the emotional status of the patient, and will stop playing with them and may prevent scarring. And introduction of isotretinoin and steroids may be needed in patients especially when we predict scarring, as we mentioned before. We have two special situations. Just to mention them, the acne fulminans and the acne conglobata are real serious medical problems. Maybe they are beyond the scope of this lecture, but isotretinoin is used in both. It's actually isotretinoin in these cases is a cornerstone to reduce inflammation and to stop the scarring. Isotretinoin is warranted for severe and moderate acne, for acne fulminans, poorly responsive acne, acne that relapses off oral treatment, acne with tendency to scarring, acne-inducing psychological distress. And it should be introduced early when we suspect that scarring is going to happen or acne is going to last with the patient for a long time. Isotretinoin, it suppresses sebum production, restores normal keratinization, restores follicular microbial balance. It's very effective. It works on almost the main pathogenic pathways, and it is maybe, as one of the references says, it's the only not open and the only closed-end treatment for acne. The one that you can put your cards on, it's going to finish acne once and for all. But it should be under medical supervision, carefully followed, because the side effects here are many if the patient is, let's say, reluctant to go for the checkup and for the investigations. So the scars happened, whatever we try to do, then the scars happen. So when we treat the scars, what are the targets? We target the epidermis, dermis, subcutis, and we put a long-term and short-term plans. I mean, when the patient comes with scars, it's not just one technique that is good for everything. You have to read what's in front of you in the skin to put your plan. What are the tools we have here? We have the fractional laser by its two types, carbon dioxide and YAG. We have the intralesional injection of triamcinolone acetonide. We have supportive treatment we give to the patient to use at home while we treat with our techniques. We have subcision, chemical peeling, microneedling, and if the defects present there needs to be filled, then we have the fillers. I'm going to discuss the 4 items in front of you: the intralesional injection, the subcision, chemical peeling, and microneedling. Intralesional injection of steroids is the best, the simplest, the most effective treatment for hypertrophic scars and keloids. Before injection, we need to put many items into consideration. We are using steroids here. So choice of the patient and of the lesion we are going to inject, choice of the type of steroid we are going to use, the dilution, the total amount in each session, the total amount all in all during the treatment, the level of injection we are going to go through while we inject, planning of frequency, estimation of the number of sessions, and expectation of the final outcome. All should be put in mind before we inject. We can use the insulin syringe as the slide in the slide before, or the dermojet you see in front of you here. Chemical peeling is a very old, effective technique. It's a simple one. It has 3 categories: superficial, medium depth, and deep. The deep is done in hospitals by very trained professionals. It's not for an outpatient office procedure. So let's concentrate on the superficial and medium depth that we can do. We can use a Gessner solution, the trichloroacetic acid, salicylic acid, glycolic acid, lactic acid, and some concentrations of carbolic acid phenol. And we can ask the patient to use in home retinoic acid or glycolic acid creams each night, with using nutrient creams like dexpanthenol and hyaluronic acid containing creams each day. Gessner solution in dark races like us and darker, it contains resorcinol, which may cause some post-effect hyperpigmentation. So it's better we remove the resorcinol and add 3 to 5% phenol with a pigmentary diluting effect. TCA and salicylic acid are very effective, but they need good training, careful hand to use them. What chemical peeling does here is that it changes the deep scars into a more superficial ones, with the acute angles into obtuse ones. It gives better look to the skin and makes the scars less deep, but they do not treat actually all scars. This is an example of chemical peeling. The one session, this is to the left before, and then this is light peeling immediately after the frost disappears, and this is 2 weeks after the first session. The effect is good with one session with very cheap and easy to apply treatment. And this is another case with medium depth chemical peeling and the effect after 2 weeks, as you see. The Dermapen is a genius invention. I love Dermapen very much. It gives me most of the effect that I can get by the fractional laser, much cheaper and less heat effect. Synonyms are microneedling, collagen induction therapy, and the dermal stamping. To get an effect, we should go deeper into 1.5 to 2 millimeters in depth to try to cut some of the old fibrous tissue and to induce collagen. The effect appears usually within 2 months, not before. The patient should be warned about that. It's very simple to use. Maybe you can use just a local anesthetic cream before the Dermapen, and it's done in the outpatient, in the office. Here's one of my friends, my patients, to the left before, and then after the first session of chemical peeling, you see the frost. After 1 month, this is the Dermapen, and this is after another 1 month. So between the leftmost photo and the rightmost photo, it's 2 months, it's just 2 sessions, 1 chemical peeling, medium depth, and 1 Dermapen session. The effect is good, acceptable. It did not cost me much equipment, and the patient was satisfied. Subcision is another genius invention. When the fibrous tissue pulls the skin down, causing the depressed scars, then cut the fibrous tissue. You may use the knocker needle invented by the knockers, or you can use just a syringe needle like this one. I use a syringe needle. Actually, I make sure that there are no active lesions, no bleeding tendency, no tendency to keloid formation, and no systemic retinoids within the last year, please. And the best results are with the rolling hair scars we have seen before. I go into superficial subdermal with the sharp bevel up. I pinch the skin with the thumb and index. I can go through multiple points of entry, and from each point I can do piston-like to and fro movements, or fanning, or white windshield wiper. I can move it horizontally under the skin like the photo you see to the down right. And I allow for the collection of small subdermal blood clot. I do not push all the blood outside. Leave some to get a granulation tissue here. It helps. Subcision can be combined with all other therapies in front of you. So, finally, we can use chemical peeling to improve the situation in epidermis and papillary dermis. We can use subcision for dermal and subdermal fibrous strands to cut them. We can use a microneedling to stimulate dermal collagen regeneration. And we may use the punch biopsy, the punch elevation in some of the depressed scars that could not be removed by the subcision and the microneedling. Look at the 4 techniques you see in front of you. They do not cost much. They do not need much training. They need careful hand. They need you to understand what you are working on, what type of skin and what level of skin you are treating. Simple, affordable. You can do it in any clinic. Thank you very much.